Hello, everybody. Here we are talking about medical interventions and nursing management of a laboring patient, and we'll start part one before labor begins. Procedures that we might do to enhance labor or to make it more favorable. So, external cephalic version is a way of turning a baby from a breech or transverse position into a head down or vertex position. It works best when mom's BMI is normal so that you don't have to push through a lot of adipose tissue, and it works better with a normal size or small fetus so that you can manipulate them a little bit easier. And it also works better if you have adequate fluid. And the reason for that is that if there is not adequate fluid, you run the risk of a cord accident, which is when the cord gets trapped between the baby and the pelvis, or it gets compressed in some way. There is a slight chance, very rare, that you could cause a placental abruption with the pressure that you have to apply. And it should be performed in a location with access to an OR in case the baby's heart rate is non-reassuring. They usually do it at about 36 weeks. There's the risk of the baby reverting to the original position, which is called an unstabilized. Some babies are just determined to come out the wrong way. Okay, so indications, breech or transverse lie at 36 weeks. You can go ahead and proceed if the NST, non-stress test, is reactive. Remember, that's reassuring for fetal well-being. If there's adequate amniotic fluid volume. If the presenting part is not engaged in the pelvis. Once it's engaged in the pelvis, it's really difficult to sort of unjam them. And if the size is appropriate for gestational age. Big babies have a hard time with this. Contraindications, we have a history of placental abruption. Because there is that small chance. If you have severe preeclampsia, this is not considered a good viable option. Or any signs that the fetus might not tolerate the procedure. If you're seeing decelerations, if you have oligohydramnios, which is too little amniotic fluid, suspected macrosomia, if you can visualize a nuchal cord, which is an umbilical cord that's wrapped around the neck. On ultrasound, do not proceed with this. You could actually strangle the baby and cut off their blood supply. If you have a placenta previa, because we're not looking to have a vaginal delivery with a placenta previa. And if mom has had previous uterine surgery, there is a small risk of uterine rupture. So the things that we might do during aversion is to administer tocolytics to relax the uterus. Those tocolytics that we don't use too often for preterm labor can be used to relax the uterus so that it's more favorable to aversion. Using the ultrasound to locate the position of the fetus and placenta. This is often done under epidural anesthesia because it's not always a comfortable procedure. Sometimes they have to put a lot of muscle into it. And the use of electronic fetal monitoring to detect non-reassuring changes in the fetal heart rate, which again goes with cord accident, placental abruption, and uterine rupture. Okay, and we're going to continue into cervical ripening and induction of labor in our next video.